All right, so the next one we're going to talk about is sickle cell anemia. Sickle cell anemia is an autosomal recessive disease, but that means that the patient has to be homozygous. They have to have two genes for this disease to have it. But some people who are heterozygous, they have one sickle cell gene and one normal, will have some reduced expression. So they'll have some symptoms and occasional sickling. It is seen most often in patients of African or Mediterranean descent, but don't assume that that's always going to be the only place that you see it. We see it, like I said, most often patients of African or Mediterranean descent. That's believed to be because the gene for sickle cell is connected to immunity, some native immunity to malaria. So it developed in areas where malaria is endemic. So the pathophysiology, so what happens under certain condition, red blood cells change to a sickle cell shape or to a sickled shape. So we have these round red blood cells. Some conditions happen, and we're going to talk about what those triggers are, but a trigger occurs and those cells will change to a sickle shape. So that means if we've got, instead of round, happy red blood cells, we've got sickle shaped ones, they pile up. So we get these pile ups that block arterial blood flow, okay? Or they can block venous blood flow. And it's not a clot because this doesn't have to do with clotting factors. It doesn't cause a clot, it's a pile up, all right? So what does that happen? Or what does that cause to happen? We get ischemia and potentially tissue death past the point of that plug. So what we see a lot of times is extreme pain, and that pain is whatever tissue is not being perfused at that time is dying. So it is the same mechanism of pain as a heart attack, and it's important to understand that because patients are frequently accused of drug seeking. I won't say frequently, patients with sickle cell are universally accused of drug seeking at almost every time they are seen in healthcare because of the amount of pain that they're having, because frequently they're living with pain and so they may not appear to be in pain, and because of some racial bias frequently. So what are the things that will trigger those red blood cells to sickle? The most common ones are hypoxia, fever, dehydration, infection, vasoconstriction, okay? So when the weather changes or when someone gets a cold, pneumonia, things like that, those things tend to trigger sickling. You need to understand that fetal hemoglobin does not sickle. So the red blood cells that have fetal hemoglobin that the baby's born with don't sickle. So they don't have that first crisis at birth. They have that first crisis after a few months when the cells with fetal hemoglobin have died off and they've made cells with adult hemoglobin. So those sickled cells have decreased capacity for carrying oxygen. And they also break down faster. So because they don't carry oxygen as well, the patient may have shortness of breath and they may have lowered O2 sat. They may not, but their O2 sats may be a little low. The sickled cells pile up, causing obstruction. So they have tissue ischemia and infarction, tissue death. They also cause inflammation in the vessels. And when we talk about sickle cell crisis, we're usually talking about a vaso-occlusive crisis when the perfusion to whatever particular area has been blocked by those sickle cells, okay? Those sickle cells break down faster, so the patient develops severe anemia, and the anemia usually becomes severe enough that they start putting out immature red blood cells. So they will have reticulocytosis. So on there, they'll do a blood smear and see large numbers of reticulocytes or immature red blood cells. And because of the breakdown of those damaged cells, they will have jaundice. And usually that reticulocytosis and jaundice comes a day or so after that crisis begins. Okay. So there are some complications aside from the vaso-occlusive crisis, which is very painful. Please remember, we're not just talking about pain, because usually the patient's experience right then is one of pain, and they're concerned about getting their pain relieved. And if we're thinking of it as only pain, we sometimes prioritize that lower. We're like, well, yeah, they're hurting, but it's just pain. Pain won't kill you. Remember that pain in sickle cell indicates damage. That pain indicates that tissues are dying. So if they're hurting, tissues are being damaged at that time, and we need to be addressing it. Fortunately, the things that help the pain also tend to help decrease the sickling and vice versa, or decrease or increase perfusion and vice versa. So some complications, sometimes they can get a pileup or a vascular occlusion that allows, that stops the blood from getting out of it, decreases venous return from the liver or the spleen. So you have really large vessels and you're putting a lot of blood through the liver and the spleen. They're both very vascular organs, in particular the liver. What if the veins going out of that are blocked? You can put, how much blood can you put in your liver if it can't get out? And the answer to that is all of it. That patient can actually become hypotensive and have hypovolemic shock because all of their blood volume is being put into the liver and can't get out, or the spleen and can't get out. So when you think about, you're putting all of your blood into this very vascular organ and it can't get out, not only can that cause decreased blood volume and shock, but that organ becomes engorged and may actually rupture. Okay. So that's one type of complication. Another complication is aplastic crisis. Sometimes if someone who has sickle cell has a viral illness in particular, it can actually cause their bone marrow to just stop making red blood cells. Well, they already don't have enough and they turn into this weird sickle shape that won't perfuse, and they break down faster, and now their bone marrow stops making them. So that's an aplastic crisis. They can have a hyperhemolytic crisis, and that's they're destroying red blood cells faster than they can make them. It causes severe anemia, jaundice, and reticulocytosis. And they can have acute chest syndrome, and that's when the vascular occlusion, I want you to think about the little tiny vessels that perfuse your tissues, right? That's where the occlusions are going to happen first. So those little tiny vessels get blocked by sickled cells, and that causes pain and inflammation. And over time, they have chronic joint pain, things like this. Now, for acute chest syndrome, I want you to think about what happens if the little tiny vessels that feed the lung tissue, what happens if they get blocked? The lung tissue becomes ischemic and inflamed. One of the first things that happens is it stops making surfactant. And so they have this presentation that looks like pneumonia or ARDS, and it can be really dangerous. Some other complications, they can have stroke. Stroke is actually not uncommon. They can have heart attack because of those blockages. And there can be damage to other organs because of the ischemia. All right, now we've talked about the patho and we've talked about the complications. And remember that I said the patho is not clots, it's that those cells that should be round turn into sickle shapes and pile up. But also, some patients with sickle cell have an additional issue with their blood, and it actually does clot too quickly. Okay, it's a factor S. So sometimes they will have a clotting issue on top of the sickling issue. So that may be, that's going to have to be treated differently, right? Okay, So diagnosis for sickle cell, this is included in the newborn screen. So babies now should be getting a diagnosis soon after birth, and that allows for early treatment. Couples, if family members, if someone has family members affected, that couple may opt for genetic testing to see if they carry the gene for sickle cell. The initial crisis is usually in late infancy or toddlerhood, and that's because of that fetal hemoglobin. And so if they're not diagnosed at birth with the newborn screen, they would be diagnosed hopefully with one of the earlier crises. Management. So if a patient has sickle cell, the highest priority is to try to prevent crisis. So that patient needs to stay hydrated. They need to do what they can to prevent infections. That means getting flu shots, getting pneumonia shots, avoiding people who are sick. And there's some recent evidence that prophylactic antibiotics in children with sickle cell is beneficial in decreasing the number of crises. We also want to make sure that they identify and get treatment early for infection. So they don't need to get really super sick before they go to the doctor. They need to identify that they're sick and get treatment to prevent infection and prevent a sickling episode. We also want that patient to avoid hypoxia, so we don't want to put them in a situation where their oxygen level gets low. They need to avoid extremes of temperature and other environmental extremes. So really cold is a trigger for a lot of patients because it causes vasoconstriction. So we want them to avoid extremes of temperature and going back and forth, and other environmental extremes. Probably this client would be cautioned about going to higher altitudes where the oxygen is thinner, let's say thinner, where the oxygen molecules are farther apart. And so you have to get more air in to get the same amount of oxygen, because that can be a trigger. Okay, so think about the things that are going to trigger that. Now, think about a patient who is an athlete or who wants to go swimming with their friends, or think about the things that kids want to do and how that how we could help that child participate in as normal life as possible while doing what we can to prevent sickle cell crisis. There is a medication that is taken by quite a few people with sickle cell, and it causes the formation of red blood cells with hemoglobin that is more similar to fetal hemoglobin than to adult hemoglobin, and that med is called hydroxyurea. So that's prevention. When they have a vaso-occlusive crisis, what is the appropriate management? Rest, hydration, and electrolyte replacement. I used to go around to those kids' rooms. Every hour, I want to know what they want to drink, and I want to give them 8 ounces of what they want to drink. Okay. We want them hydrated. They're also going to be on IV fluids, and as long as they don't have cardiac or renal complications, they're going to be on IV fluids at a fairly high rate because we want to hydrate them. Not only does hydration help stop the sickling, but also if we fill their vessels up with water and expand them, okay, with extra fluid, that actually gives some space for those blockages of the sickled cells to break up. Okay, we expand the volume. We need to manage their pain, and this is absolutely crucial. And currently there is a crisis of pain management, and patients with sickle cell are frequently left in excruciating pain. So this is really, really important. As a nurse, you can advocate for adequate pain management for these patients. Morphine and hydromorphone are preferred, and that's because they vasodilate. So not only can they relieve the pain, but also if we vasodilate, while we're giving those extra fluids, we can hopefully break up some of those blockages and help promote better perfusion. If they're anemic, they will get transfusions. If they're at risk for stroke, they may get like recurrent transfusion therapy. They just may have scheduled transfusions, because if they're at risk for stroke, keeping their red blood cell count high enough with healthy red blood cells can be beneficial in preventing that. Patients who get a lot of transfusions, though, have high iron levels, and so then they may need chelation therapy to be able to excrete that iron. We're still on treating a crisis. Whatever caused it needs to be managed, and a lot of times that's going to be an infection, so their infection needs to be treated. We only give oxygen if they're actually hypoxic. We used to give oxygen to everybody with sickle cell to try to maximize it. But if they don't need oxygen, it actually, giving them extra oxygen actually suppresses red blood cell formation. It also doesn't reverse the sickling. It doesn't reduce the pain. So no oxygen unless they're hypoxic. If they're unable to get the sickling to stop, they might do an exchange transfusion. If a patient has recurrent splenic sequestration, so over and over, blood goes into their spleen, but they get a blockage because of those sickled cells and it can't get out. If that happens over and over, they can do, actually it happens more than once, they can do a splenectomy. But anytime, you're going to hear splenectomy multiple times in this lecture, anytime the spleen is removed, that patient has a lifelong increased risk for sepsis because the spleen plays an important role in the immune system. Okay. Sometimes the spleen atrophies in childhood, and then that takes away the risk of splenic sequestration. There is now a cure option for sickle cell. Sickle cell can be cured by a stem cell transplant. So we ask, why doesn't everyone just get a stem cell transplant? They are, first of all, very expensive, but also they are very dangerous, and they involve usually a 3-month or more hospitalization. We're going to talk later about what stem cell transplant involves, but it's not a really simple thing, and that's why more patients don't have them. Education for parents. We want parents to treat this child as a normal child, but to also be aware of their additional needs. They need to be hydrated. They need to be paying close attention and identify infection and other sickle cell triggers for that child. Parents need to know that bedwetting is common because they have an increased fluid need. They need to be drinking more fluid. They have delayed kidney maturity because of that poor perfusion. So their kidneys mature more slowly. So bedwetting is very common. We need to help parents understand that and learn ways to deal with it. They should have a medical ID bracelet. The school needs to know about the sickle cell and know what the treatment plan is. And then the child will need genetic counseling as they get older. The family needs genetic counseling. If a family has a child with sickle cell born, they need to know that a child with the same parents has a 1 in 4 chance of having sickle cell. We also need to give lots of support. This is a disease that interferes with having a normal childhood. Parents often feel guilty and they have a fear of losing their child. Siblings may be afraid of losing the child. They may feel guilty. They may also feel very resentful of all of the time and attention that the sick sibling requires. The prognosis, most people with sickle cell live into the 5th decade of life now. Most children can live a normal life between crises. Growth delay and pubertal delay are very common. A lot of times these kids end up just being smaller. As adults progress with more and more, if they have a lot more crises, they begin to develop some disability. So preventing crises prevents disability down the road. Long-term opiate use causes increased tolerance, so it takes more opiate to relieve their pain. It causes physical dependence if they're taking it frequently. So if they're having to take opiate pain meds regularly, then they're going to be physically dependent and will have withdrawals. Tolerance and physical dependence are not the same as addiction. Addiction is mental. Patients who have sickle cell are frequently, almost every admission, they're assumed to be drug seeking. If they actually, if they have a stem cell transplant and they are cured, that requires a major psychological adjustment. So someone who has lived their life with a life-limiting illness and suddenly that's cured, now they have to change how they're approaching life. What are they going to do now with this life? Okay, that is all for sickle cell. Next, we'll talk about beta thalassemia.